Hello everybody, my name is Susan Hogan. I'm one of the registered nurses in cardiac rehab here at Halton Healthcare. I'm here to talk to you about how the heart works and the tests and procedures you might go through as a heart patient. So this is about the heart. The heart has 4 chambers. There are 2 top chambers called atria, and there are 2 bottom chambers called ventricles. The heart pumps about 5 liters of blood a minute. That's the heart pumps all the blood throughout the whole body. It pumps about 5 liters of blood a minute at rest, more when you're running or exercising, or about 7,200 liters a day. And you can actually see it beating very, very small beats and very fast beats in gestation, in the mother's womb. It's going about 300 beats a minute. But by the time you're born, it's down to 100, 120 beats. And as you get older, the heartbeats get slower and slower, usually until you're an adult, and that's about 70 to 90 beats a minute at rest. Many of you might have a lower heartbeat than that, and it might be because you're an elite athlete, if you're in the Olympics, or you're on medication like beta blockers, which slow the heartbeat down on purpose to help the heart heal. The blood flow through the heart goes through the right atrium, goes through the pulmonic valve, or the tricuspid valve, into the right ventricle, goes through the pulmonic valve into the lungs, where it picks up oxygen and gets rid of carbon dioxide. It comes back into the left atrium, through the mitral valve into the left ventricle, and out into the aorta. The aorta is the biggest artery in the body, and from the aorta comes all the different other arteries. It looks like it's bright red. It has the bright red oxygenated blood going towards all the cells in the body. On the right side of the heart, you can see it looks like blue. It's not really blue, but it's a darker red, but we just differentiate it with the paint. So that's the blood flow through the body. It goes through the right atrium, through the tricuspid valve, through the pulmonic valve into the lungs, back from the lungs, left atrium, left ventricle, into the aorta. I'm going to talk to you not just about how the heart pumps, but also about the electrical system of the heart. I'm going to talk about the coronary arteries of the heart and the valves of the heart. The heart has 4 different valves, and they keep the blood moving forward. They can develop problems if they don't open or close properly. The ones that are the most, have the most problems if they need replaced or repaired is on the left side, where there is more muscle and there's more pressure against those valves. These are pictures of the valves that you can see through here, and I'll show you another picture up on the slide. But they can, over time, they can get weaker, and they need help to be so that there's no backflow. When we listen with a stethoscope to your chest, we can hear the heart beating, and it goes bump, 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 bump. That is normal. That's called the lub-dub of the heart. But if the heart is not beating or not opening or closing properly, you can get a murmur. Sometimes the doctors can hear when they're listening to you, and they hear it's more like a shoo-dub, shoo-dub, shoo-dub. I'm exaggerating a lot, but there's different gradations of the murmur. That's what a murmur is. And it's caused by the heart not closing with a nice snap shut. The coronary arteries. Coronary arteries are the very first arteries that come off the aorta. The aorta, remember, has all the other arteries come off the aorta eventually. The very first arteries that come off the aorta, off the aortic root, goes back and feeds the heart. There are 2 major arteries that come off the root of the aorta, the right and the left. And here's a good picture of them, right and the left. Or here. There's a right one and a left one. The left coronary artery branches off and goes into the left anterior descending artery and also the circumflex artery, which goes around to the back of the heart. Each coronary artery feeds a specific part of the heart. So we can see if there is a blockage in one certain part of the heart, we can see if it's from the front part of the heart, we know it's probably the left anterior descending artery or one of its branches that has decreased blood flow, causing the injury. Now the heart is in a sac called the pericardial sac. You don't have to remember that, but it stays in place. It's like a baggie over the heart, and the coronary arteries are underneath that on top of the muscle. You can see the coronary arteries on top, but it stays in place with that pericardial sac. I'm also going to talk to you about the heart's electrical system. Did you know that the heart makes its own electricity? Well, it does. In the there's a sinoatrial node, a little node up here from the right atrium. It's about 10,000 little cells that are specific to that part of the heart that generate the pulse. And when I say generate the pulse, electricity, it's just the sodium and potassium going in and out of the cells. One thing about heart muscle is that it moves the electricity around the heart very easily. So the muscle, or the little area here, generates the pulse in the SA node or the sinoatrial node. This pulse, or this electrical generation, goes around the atrium, and it goes around like this. And it stops right there, very briefly. But it makes the atriums, when you have electrical impulse going through muscle, what happens? It contracts the muscle, right? So it makes those muscles smaller, making this pump all the blood down into the bottom part of the heart. So that's the first lub that you hear of the valves closing after this goes. So this stops briefly through the AV node, which goes a little bit slower. It stops briefly, and then this impulse goes down the middle of the heart and out on the outside, and making the bottom part of the heart contract. Bottom part. So the top part and the bottom part, top part and bottom part, moves the blood so many times a day. And that creates it's like the ever-ready battery. That is your node. Now, if this sinoatrial node has a problem, it's damaged somehow, there are other nodes in the heart that will take over. Every cell in the heart has the potential to give an extra heartbeat. But usually this is the strongest one, and that would be the one that would be taking over. The AV node is another pulse generator if this one is not working, but it goes slower and it looks different. You can see it on the ECG. And there are some that can be generated in the ventricles. They're not as strong, not as much contractile force, these pulses that come from the ventricles. This is a picture of one lead of an ECG. And this would show one of the leads on an ECG called lead 2. And this would be the little impulse that comes from the SA node, or the sinoatrial node. And it gives a little blip like that on the electrical paper. And then it briefly stops going around. This would be the electrical impulse going through the ventricles, and then this is just repolarizing to get back to the first pulse again. And then it generates on and on and on. Have you ever heard of heart failure before? Heart failure is sometimes called congestive heart failure. It is treatable, and it sometimes occurs after you've had heart damage, like over time, coronary artery disease, or a heart attack, or ongoing high blood pressure, not just one incident, but over time. It means that the heart is weaker, the heart muscle is weaker, and it's unable to keep up with the body demands. And so it's not as contractile. Or conversely, it can also mean that the heart is very stiff and it's not opening and closing very well. So what happens is that there is fluid that leaks out into the lung. It's backing up from the blood. So you can hear it. It sounds like fine crackles. If you listen with a stethoscope, the nurses and the doctors will listen, and it sounds like very fine crackles, like if you're rubbing your hair together. Very, very fine crackles. That's the sound of water going through the lungs, or fluid going through the lungs, because the body is just, the heart is not keeping up with the body demands. Heart failure can also come from rapid irregular heartbeats over time. It is treatable, and we see people living a long time, much longer than previously. This is a picture of a dilated heart, and what happens when the heart is dilated is it doesn't have as much contractile force. And you can see that there is a weaker left ventricular wall that would usually be very strong, and it doesn't have enough push to get around the whole body. Then there's a picture of a thickened left ventricle. You can see that there's not enough room inside the ventricle to have enough cardiac output per beat. Now, what happens when you have some plaque buildup in the heart, in the coronary arteries? Have you ever heard of hardening of the arteries? That's what atherosclerosis is, or the plaque buildup that occurs inside the coronary arteries, the red coronary arteries. If you've got plaque buildup, well, first of all, plaque is a mixture of that LDL cholesterol, that L for lousy cholesterol, or low density lipoprotein. It's also got some calcium in it, and it's got some inflammatory molecules that bind together and it's like a paste at first, like toothpaste in the consistency, and it lays down inside the walls of the artery. And there are different, it lays down. The problem with having plaque buildup inside your arteries, it gets hard over time, so it's hard, and there's more pressure. It's also more vulnerable. We call it the vulnerable plaque. So it's more likely to get fissures or lesions inside, which attract platelets. Platelets are the part of the blood cells that cause clots. So if you get a cut in your hand, you get a clot over that cut. Same thing happens inside the coronary arteries, but what happens, you've got a small space, so it decreases the space, and the blood flow going forward or going downstream is blocked. And you might feel angina. Angina is the pain associated, or the discomfort associated with not getting enough oxygen to your cells in your heart. And your heart is crying out, I need some more oxygen. And I'll tell you what the difference is between angina and a heart attack. A heart attack is also called MI, or myocardial infarction. And it means that there's decreased blood flow to the point where it causes cell damage. Angina is pain or discomfort or a sensation above the belly button that you might feel that's associated with decreased blood flow, but it's temporary and it goes away, and there's no lasting cell damage. So what happens when you have a fissure in the plaque? You can see the platelet aggregation causing decreased blood flow. And if you have unstable angina, that's a different thing altogether. That means that there's plaque buildup, but it's not occluding all the way. If you have stable angina, it usually happens when you are doing something. There's some kind of stress that you're putting on your heart. It could be physical stress, it could be emotional stress, it could be mental stress, but it goes away when you stop that stress, you stop running or whatever. Unstable angina can happen if you're asleep in bed or you're not doing anything. It is more of a warning sign, and you should let your doctor know if you have that kind of angina. It's more of a warning sign that you could be more at risk for a heart attack. But if you have an infarct or a myocardial infarction or a heart attack, it means that you are not getting the blood flow to that part of the heart, and time is of the essence to get an intervention to make more blood flow to that part of the heart. Otherwise, there's cell damage that can be lasting and cause problems down the line. Now, atherosclerosis doesn't happen all at once. It happens over time. And you can see on this picture, it can happen in the second or third decade of life and then gradually build up until at the end you can get a lesion that causes the platelet aggregation to cause the decreased blood flow that causes the heart attack. So what happens when you have angina? We call angina anything above the belly button. Like I said before, it can be the classic, oh, I've got chest pain right in the center of my chest, radiating down my left arm, but that's not necessarily always the case. It's the Hollywood version. So if you have anything, we say anything above the belly button, that is new. We know it's not your gallbladder pain, for instance. You know that this has been diagnosed with gallbladder pain, that's okay. But if you don't know what it is, and especially if you're higher risk, like if you've had a heart attack or any heart problem before, you're more at risk than the general population of having another heart event. So if you have chest discomfort, if it's going down your one or both arms or shoulders, you can even have neck pain or jaw pain. You can have front or back. It can be pressure, not pain. I've had some people say when I've asked them, do you have chest pain? They said, no, but it's pressure. You have to be careful. Don't discount just a pressure, or it doesn't have to be pain. It can be accompanied by shortness of breath. In fact, it often is. Or heavy sweating. Fatigue or pain in the back between the shoulder blades. More common in women than men, but it can be seen in men. Nausea and vomiting as well. So what happens if you have this chest discomfort and it goes away? You tell your doctor. Your doctor is probably going to send you for a test. There are different types of tests I'm going to talk about. So I'm going to talk about the diagnostics. What happens if you go into emergency room for chest pain? They are going to take some cardiac enzymes. Cardiac enzymes are just enzymes that are emitted by the heart that you can pick up in the lab, you can see in blood, and over a certain amount, it can tell if you're having if you've had heart damage. Every organ in the body will emit some kind of enzyme if it's damaged, and these are specific to the heart that you can measure. They go up and down over 24 hours though, so if you wait, say if you're at the cottage and you wait before you come back to the hospital, and then you present to the emergency room and they'll take this test, it won't show up because it'll have already gone up and back down to normal if it's over 24 hours. So that's one reason why we want you to come in as fast as possible. They'll do a resting ECG. A resting ECG is a strip of a lot of paper with a lot of electrical impulses shown on it. You've all probably had one. There's 12 different views, so 12 different windows you can see of the electrical activity of the heart. There's an exercise stress test, which you probably all know and love. You've all been through it if you've been in the cardiac rehab program. And that involves going on a treadmill usually. We have some that you can go on a bike, for instance, but usually it's on a treadmill, and every 3 minutes it'll go up higher and faster. And while you're attached to an ECG, and they even have stress echocardiograms, which will do an echocardiogram before and after going on the treadmill. And you can have a plain echocardiogram without the exercise test. You can have a stress thallium scan, which it produces images on a screen that shows, first you'll have dye that goes in your vein. It gets picked up by the heart, and wherever it is not picked up in the heart, it shows a kind of a black space, and that's like a cold area that isn't getting the blood flow, showing that there's damage. And then the angiogram is another type of diagnostic test, and it's a dye test of the heart's arteries, and I'll go more into that because that's an important one too. It's kind of the gold standard at this point. There are other tests that I'll talk about at the end, the CT scan and the MRIs as well. So the cardiac markers I've already talked about. In Halton Healthcare we use the troponin that will go up and then back down. There are other enzymes that are more specific to the heart, but we use this one, and it's a good one. And it shows if there's heart damage. The cardiology department is where you'll get many of these tests done. You might have to go in another part of Halton or Peel to get the other tests. This is a picture of the ECG that I was telling you about. Every little part of the ECG is measured out. There's little it's on a graph paper, and over here it goes from left to right in time, and then amplitude of the electrical activity going up and down. As I said, there's 12 different views, and then there's just a rhythm strip on the bottom of lead 2. Every little part, as I said, is mapped out by the doctors and nurses, so you can tell we can tell a lot through that ECG. It tells where that heart beat is coming from, how fast it's going, and if there's any damage. If the heart is having a heart attack, it can often show right then and there, or if it's having ischemia, meaning decreased blood flow but not an actual heart attack. It tells us a lot, that little ECG. This is actually a picture of someone having a heart attack, and you can see this part of the heart might go up. It's elevated. It's called the ST elevation. And if it's over a certain amount, they know that that is a heart attack. And you can tell by where the lead is, you can tell what part of the heart is affected. And if you know what part of the heart is affected, you know generally which artery is supplying that part. But you still need to go get a test to find out. If we do see an ECG like that, we do run. We do not walk. It is an important concept that we get to you right away. We want you to get the fastest intervention that we can. So you might not see us running, but we're running. It is important for us to get you that care right away. You'll call emergency or 911 if you have chest pain. Please do not drive yourself. You can cause harm to yourself and others with a car crash. Also, if you call 911, you'll get the EMS, you'll get the ambulance service that will come and take you to the right place at the right time. And you're not behind other people in the emergency room lineup, someone with, say, a sore knee. You go to the front of the line. That is triage. So we want you to not wait for that intervention. And that is one way. If you call 911, they'll take you right to where you need to go. And also other things about if you call 911 and when you call, they can do things like give you aspirin, they can give you oxygen if you need it, they can give you nitro spray, they can do an ECG, they can even defibrillate. Defibrillate is that the jolt of electricity that can stop your heart briefly so that your regular rhythm gets back. And that's if you are having a certain type of rhythm. So what happens if you have a heart attack? I want to just let you know that time is of the essence. Time is tissue. The longer you wait, the more damage can be done. So that's why we want you to go and call 911. In the emergency room, what are they going to do? They're going to quickly get you in there. They'll ask you what happened. What were you doing? What kind of pain are you having? There's a whole series of questions that they'll ask. At the same time, they're looking at you. They're looking at your skin color. They're looking at your lip color. They're seeing if you're sweating. They're checking you out to seeing what your heart sounds like. They're taking a blood pressure, pulse. They'll do an ECG. They'll get that blood work within the first few minutes and send it off stat to the laboratory. And then they will give you some treatments that might be a clot busting kind of drug. Use TNK here in the emergency here. They can give you some heparin, which will make the blood more slippery to go in the little cracks to as much blood flow, to get as much blood flow as possible into the heart. And they'll take you for an angiogram. Here we send you to Trillium Hospital usually, and the angiogram means in the arteries of anywhere, but this is a cardiac angiogram. And anytime you see gram, that just means it's a test. They're checking to see what's going on. There's also a test called the ultrasound or the cardiac ultrasound, and that uses sound waves that makes a picture, and the doctors can see, especially the soft tissue and the valves, how the muscle is moving with each heartbeat. Usually we don't do that in emergency, we'll do it later on down the line. We want to see if there's any heart damage or if there's any, if part of the heart is not moving properly, and also if the valves are not opening and closing properly. That's a really good way to see if that's working. This picture of someone looking at the echocardiogram, and there's the stress test. The stress test walk platform, treadmill. The cardiolite exercise test is another test that is used like with exercise, and it shows a radioactive substance is put in the vein that's uptaken into the heart, and it shows, the image comes on, and it shows where the uptake of that radioactive substance is, and it shows where it doesn't go. So there might be dark spots or black spots that we know should be filled. And that is a good way to see where the blood flow is going into the heart. It doesn't show every individual artery, but it shows the whole blood flow going into the muscles of the heart. But it's a good indicator to see if the muscles are getting enough oxygen. And there's the Holter monitor. The Holter monitor has come a long way, but what we have done is just attach leads to your chest and do an ECG of a couple of leads of the ECG. And people wear this cassette for a day, up to 2 weeks, and it detects irregular heartbeats. If you feel palpitations or you suddenly pass out and we don't know why, the doctor might send you to have a Holter monitor just to see what your heart's doing. Some irregular heartbeats are just fine, they're benign. You might feel palpitations once in a while, but some are not. So we want to see the doctors want to see what you're dealing with so that they know how to treat it. But it tape records the heart's activity, and it detects any problems in the rhythm or any electrical changes that might be associated with a sensation like angina. The doctor might want to see what exact heart rhythm you're in. This is a picture of a normal sinus rhythm. And like I said before, every little bit of that is measured out. They all have certain parameters to be within normal range. And if you're outside of that, we know that that heartbeat is coming maybe from another part of the heart. This is sinus bradycardia. Sinus bradycardia, all that means is it's coming from the sinus node, but it's slow. And it can be because you're an elite athlete or you're on medication that slows down the heartbeat. Not a problem. It's just a slow heartbeat. Unless it's too slow and you're not getting the cardiac output that's going to your brain, you might feel lightheaded and dizzy. If that's the case, then tell your doctor. You might have premature atrial contractions. Again, these are benign. They don't mean, they're not going to necessarily do anything about this. It might be a little bit of a skipped heartbeat. These are premature ventricular contractions that the ECG or the Holter monitor might pick up. If you just have once in a while, you have one of these contractions or ventricular beats that are coming from the bottom part of the heart, then not a problem. But if you have a lot of them together, they can deteriorate into a rhythm that is very bad, and we want to take care of that. And the doctors will want to know what it is in order to treat it, because it can decrease your cardiac output, and at the very least you can pass out. Then there's atrial fibrillation. Have you ever heard of atrial fibrillation? Atrial fib for short. A lot of people get this, especially as time marches on and we get older. What happens with atrial fibrillation is that the top part of the heart is just fibrillating like a bowl of jelly. It's not really moving any blood in the top part of the heart. But every once in a while you'll get electrical impulse that stimulates the bottom part of the heart. So the bottom part of the heart is beating, but it's irregular. The problem with atrial fibrillation, it tends to go very fast, so it needs to be slowed down. And it also, if the top part of the heart is just fibrillating, then clots can form in the top part of the heart. And if one breaks off, it can cause a stroke. And we don't want that. So you need to be on blood thinners for the rest of your life, as long as you have atrial fibrillation. But they want to know if you have it so that they can treat it. Now this is a picture of the coronary angiogram. What is the coronary angiogram? It is colorless dye that is injected into the coronary artery. There's a wire that comes backwards from the aorta into the root of the aorta, right into the coronary artery. These wires are very fine, and they'll inject a dye that's picked up on X-ray, and it shows the narrowing. It shows the blood flow into the actual coronary arteries, and it can show where it is narrowed. So it can pick up very easily where the narrowing of the arteries are and where it might need fixed, if it is, and how much it's narrowed. And there's a screen that they have there. They can measure exactly how much narrowing there is. So there's the special pictures taken with a special X-ray camera. It's also good for assessing the valves of the heart and the way the heart pumps. What happens now if you have known coronary artery disease? They know that you have narrowing of the arteries. What now? What do? You can have angioplasty, which is every time you see plasty at the end of the word, that means that they're doing something. They're changing something. Angioplasty with the stent, and I'm going to show you what that is, or coronary artery bypass graft, or other surgery, or medical management. Management is management with medication and lifestyle, which is also important for everybody. So look at this picture. You can see before the angioplasty, you can see that narrowing of the artery there. You can see a balloon, which is placed inside the artery. And After the balloon has been there, stretching the artery out, they deflate the balloon and take it out. You can see the better blood flow, which is better for you to manage your life. You don't get that chest pain, that angina anymore. I'm going to show you what it looks like to have one of these stents, what the stent looks like. It's very, very tiny. There is a balloon on the end of this stent, or a balloon on the end of this wire, and the stent is on top. I don't know if you can see it. The stent is like a wire that is over top the balloon. Once they open up the balloon, and the stent is over top the balloon. This is how big the stent is. Very, very tiny. It's almost like a clicky pen. You know the little pens inside, the little springs? And it's like a scaffolding. It's opened up with the balloon underneath against the inside of the artery, against the artery walls, against the plaque. And so the balloon is inflated to squash that, and then they deflate the balloon, take it out. It's pretty remarkable. They can do that. It restores normal blood flow right away, so you should not be having any chest pain after that. There's a picture of a stent. Used to be the only insertion site was the right groin, that they would push the wire up against through the artery. But nowadays the wires are getting much finer, so very often they're put in the wrist now. Just easier on the body, because right after you don't have nearly as much bleeding or bruising as a side effect. The drug-eluting stent means that there is a certain drug that's actually in the stent, and it is emitted over time to prevent the platelets being drawn to that area that's still a little rough. You need to be on the Plavix or Brilinta, one of those medications, for usually a year, sometimes longer. And it's because it takes a while for the inside lining of the artery to be nice and smooth again. So you don't need that anti-platelet medication to prevent the clot formation. Usually use it for a year, but you can use it up to 2 years or sometimes even longer. They won't use a drug-eluting stent. They'll just use a bare metal stent for people who might need a big surgery within the next year, because they would not be able to be taking Plavix or Brilinta. So if you need an aneurysm surgery or something that a big internal surgery that you could bleed, we don't want to give you antiplatelet medications that make you bleed more. Okay, surgical procedures. There's different ones. Coronary artery bypass graft, there's pacemakers, there's implantable defibrillators. I'm going to talk about valve replacement or repair up to heart transplantation. So what happens when you have a bypass graft? This is, again, the model of the heart. You can imagine if you have, say, a lot of plaque right here, say the left anterior descending artery, or just at the start of it up here, which is affecting the blood flow going downstream. If it's over a certain amount, the doctors can, or if you have a lot of areas that are affected, too many to have a lot of stents, you can have a bypass graft. It's just a detour of the blood flow bypassing the area that has narrowed arteries. So this is one idea. Pretend this is the artery. This is called the left internal thoracic artery. It feeds the chest wall, muscles. You can do without it. You have other blood flow going to it. but they'll snip off the end and bypass where that is, bypass where the blood flow is narrowed. Or you can take off another artery, say from the right, usually the right radial artery from the right forearm, because you've got two arteries there. You can do without one. And you'll put a little hole in there, attach it there, and bypass. Does that make sense? So that's what a bypass is. But we know it is a big surgery. We know you need to be on morphine or some kind of medication to reduce the pain right away. There's pacemakers. What's a pacemaker? A pacemaker is a pulse generator. If your heart is not beating enough or enough to keep up with the body demands, or if it's beating too fast or too slow. Usually there's a little pocket right underneath the clavicle here. It's just sewn in there, threaded into the big vein that goes into the right atrium. There will be one lead very often that's placed in the right atrium and another lead that goes into the right ventricle, and it stimulates the heartbeat. And it makes the heartbeat, it makes the muscles contract, just like the regular heart pacemaker of the heart would do. You can see if it is a pacemaker beat, and if you have a pacemaker, you would be seen every few months anyway. And the doctors will see how often you need to use the pacemaker, because this senses if you need it, and then it'll give you that extra pulse. It can override if it's going too fast as well. If your heartbeat is going really, really fast, it'll override it and make it slow down. So they're pretty good. Now, there's always new things going on in the cardiac world. And nowadays, they're making a new type of pacemakers that is still partly in the experimental phase, but they're implanting them through the wall of the chest onto the outside of the heart. And it's a pacemaker that's just, instead of going internally, it's kind of the outside of the heart. But it's doing the same thing, showing great promise. Battery life is up to 10 years. It depends on how often it's needed. And what they do is just take it out. It's sewn underneath the skin. Take it out every 10 years and then put another battery in and put it back in. Sometimes some pacemakers can detect if you're exercising and speed up because you are exercising. There is a type of pacemaker called an implantable defibrillator. It looks very much the same. It's quite a bit bigger, but it is also placed in here and again goes through the right atrium into the right ventricle. And what it does is it senses if the heart is going into a rhythm that is lethal. It's only if you're having a ventricular tachycardia or a ventricular fibrillation, where the heart just is not moving. It needs to stop. It needs to be defibrillated in order to stop so that the regular pacemaker can take over. So that's another tool in the toolkit for helping your heart. I'm going to talk about valves now. Valves are needed to replace if there's a damaged valve, if the valves are not opening and closing properly. And usually the valves that are most likely to get damaged over time would be in the left ventricle and or the left side, because they have the most pressure against it, unless it's a congenital problem. Then you might need the right side of the heart valves as well. they come in different ways. You can have a tissue valve, or you can have mechanical valve. The mechanical valve is often made out of metal and some other substance, but it's not a tissue valve. If you have a metal valve, it lasts a long time, but you need to be on blood thinners for the rest of your life because you can get clots forming on it. Or you can have a tissue valve from a pig or cow. It is not the actual valve from the pig or cow, it's the tissue that's been reformed into this valve. And for this type of valve, they used to not last as long, but now they're getting longer and longer lasting as time goes on. And you do not need to take blood thinners for that type of valve. There are new types of valves that are pretty amazing that you go in with, it's like a stent, like a big balloon. And I'll talk about that later in a minute. This is why you might need a valve replacement. If the valve is not opening or closing, it gets stenosed or it's not opening or closing properly. There are always new techniques coming up in the, like I said, in the heart world. Adult stem cells is one kind of intervention that it's not in hospitals yet, but it's showing great promise, where they would inject adult stem cells from your own adult cells, and they are manipulated by a lab, many different steps. And it promotes new growth. It goes over the diseased heart cells and making new heart cells. Pretty amazing. We're not there yet, but it is, the technology is advancing. CT scans are also showing greater promise. Before CT scans were used, there was a lot of radiation given in the CT scans, and also they were showing a lot of false positives. So they were showing decrease or stenosis, more stenosis inside the arteries, decreased blood flow. But it turned out not to be really true. It's just showing more calcium buildup than anything. So people were going into surgery without needing it. So they weren't using that. But the new CT technologies are showing great promise, and they're being used more and more. There's less radiation, and if the showing narrowing, you would need to have an angiogram anyway if you're going to have an angioplasty, right, to see where that narrowing is. MRI technology has come a long way too. They don't need radiation. They don't give any radiation, and they're being used more and more to detect the soft tissue of the heart, to see how it's working and how the valves are working if you've had a heart disease. This percutaneous valve replacement is pretty amazing, and this is what I was talking about. The valves are being placed over this balloon and are being placed inside where the diseased valve is, that isn't opening or closing properly. They're inflating this balloon, opening it up over top, and then deflating the balloon, taking it out, leaving the new valve over the old valve. Now, when I first heard of this, I thought there is no way this is going to work, but it is. It was being reserved for the past number of years for people who were considered too frail for surgery, for open heart surgery and having valves replaced. But just in this past year, in 2019, there's a big study or a number of studies that were showing that this is working just as well as open heart surgery. It's been called non-inferior. This is changing the cardiac surgery world. So we're going to be seeing more and more of that. Pretty amazing. What holds in the future? There's lots of things. New medications are coming up, even new classes of medication, which is a big deal for helping heart for heart after heart attacks, or if you've got heart failure medication. That on the right-hand side up there, that is a picture of a left ventricular assist device, which you use to help the heart pump when it's waiting for heart transplants. You see that on the left, that is a Holter monitor. Usually what we'd had to do is have a cassette, like a purse, you're holding the whole time for up to 2 weeks. And nowadays there are ones that are being made you just put on, and then you can mail it back to your cardiologist without having to leave, not having to come in for the test to have it placed on. So there's always new things. It's pretty exciting, and you are the beneficiaries of all that knowledge. So that's my presentation. If you have any questions, you can always call the cardiac rehab program and ask one of us. You can also talk to your doctors and your pharmacists. Thank you very much.